Hi, welcome to Pharmd Guru. In this video, we are going to talk about Introduction to Clinical Pharmacokinetics, the first chapter in Clinical Pharmacokinetics and Pharmacotherapeutic Drug Monitoring subject. As we said in our introduction video, you can expect two kinds of videos from Pharmd Guru. One type is fast-track videos and the other is concept-oriented videos. Fast-track videos are useful, mainly at the time of examinations, where students used to do rapid revisions. But this is a concept-oriented video, where we explain the core concepts in detail. We suggest students to watch concept-oriented videos first and fast-track video later for better understanding. Let me explain about this subject. What are the meanings of these terms? Clinical pharmacokinetics and pharmacotherapeutic drug monitoring. First, clinical pharmacokinetics, as the name tells us, it's a branch of pharmacology. In pharmacology, we study pharmacodynamics and pharmacokinetics. In pharmacokinetics, we study about absorption, distribution, metabolism, and excretion of the drugs. And we get data like how much drug got absorbed, distributed, metabolized, and how long it takes to excrete. We get this whole data. Doctors analyze this data, and after a lot of calculations and understandings, they will find the right dose for the patient, which is technically called therapeutic dose. Side by side, by knowing therapeutic dose, we get to avoid giving toxic doses, like prevent or avoid unwanted ADRs. So, the application of pharmacokinetic principles clinically is nothing but clinical pharmacokinetics. And the goal in clinical pharmacokinetics is finding the right dose, which is technically therapeutic dose, and the goal of pharmacotherapeutic drug monitoring is to make sure the patient is getting the right dose. Example for TDM is, just imagine, let's take the drug lithium, often used for mood disorders like bipolar disorder. Lithium has a narrow therapeutic range. If the drug's dose is too low, it doesn't help the mood, but too much can be toxic, especially affecting the kidneys and thyroid. With TDM, the doctor checks the lithium levels in the blood periodically to make sure it's in the safe and effective range, adjusting the dose if needed. In this example, this person needs 1,000 micrograms of lithium for his bipolar disorder. If the patient gets 900 micrograms, the drug may not work. If the patient gets 1,100 micrograms, it will turn to toxic dose. TDM studies. The doctors check the lithium levels. If they got the report like lithium drug concentration is 800 micrograms in blood, they increase the dose to reach 1,000 micrograms. And if they got the report like the drug concentration is 1,200 micrograms, they prescribe a lower dose of lithium. Let's go to our topic introduction to clinical pharmacokinetics. Clinical pharmacokinetics is all about understanding how drugs move through the body, like how drugs are absorbed into the bloodstream, distributed to different parts of the body, broken down or metabolized, and eventually eliminated. The goal of clinical pharmacokinetics is to make sure a drug reaches the right amount in the bloodstream to be effective without being too high, which could cause side effects or toxicity, or too low, which might make it ineffective. Example, this person took a painkiller. Here in clinical pharmacokinetics we study absorption, that is, how a drug enters the bloodstream after you take it. Here, how the painkiller pill is absorbed in the stomach and intestines before entering the bloodstream. Distribution, that is, how the drug spreads through the body and reaches different organs or tissues. Metabolism, how the drug is broken down, often by the liver. Excretion, how the drug leaves the body, usually through the kidneys and urine. Based on clinical pharmacokinetic data, the doctor might adjust the dose depending on the patient's condition. Suppose the patient has impaired kidney function. If the kidneys are not working well, the drug might stay in the body longer, so the doctor could reduce the dose to avoid side effects. Let's say if the subject has fast metabolism, he metabolizes the drug quickly. Because of his fast metabolic rate, the drug goes to excretion phase quickly. So the drug, instead of staying the desired time in the body to show its action, it gets excreted. So The doctors analyze the pharmacokinetic data and finds out, okay, he has fast metabolism, so the doctor may increase the dose. That's how they analyze the data coming from pharmacokinetic studies. Now let's see how these pharmacokinetic studies are done. In these studies, subject was given a painkiller, either tablet or injection. After some time, we took the blood sample and measured how much amount of drug present in the blood. After 30 minutes, we collected the sample and measured the concentration of drug in blood, and the concentration at 30th minute is recorded. In the same way, we performed studies at 1 hour, 3rd hour, and so on, and recorded the drug concentration in blood. Here, we know drug concentrations at their respective times. Now we have to obtain our remaining data, like parameters from this table. The liquid portion of blood is called plasma, and the drugs usually traveled in plasma. If someone says the drug concentration in blood, that means technically they are referring to drug concentration in plasma. So, with this data, we draw a graph for better understanding. And since the graph is between plasma drug concentration and time, we name this graph as plasma drug concentration versus time profile. After taking the pill, drug doesn't reach its peak level in the blood immediately. It takes time for the body to absorb it, spread it throughout the bloodstream, and eventually start breaking it down and eliminating it. The plasma concentration time profile tracks this process with 3 main phases. 1. Absorption phase. This is when the drug level in the bloodstream is rising because the drug is being absorbed. 2. Peak concentration, Cmax. After a while, the drug level reaches its highest point, called the peak concentration or Cmax. Once it reaches peak, then it starts declining. 3. Distribution and elimination phases. Once the drug reaches its peak, it starts to be distributed to tissues and organs. Then, the body starts to break down the drug, usually in the liver, and eliminate it, often through the kidneys and urine. During this time, the concentration in the blood slowly starts to drop. And in this plasma drug concentration versus time profile, we can also get half-life. Here, we got 2 new terms, half-life and peak plasma concentration. Let's look at them. The half-life is the time it takes for the concentration of a drug in the body to be reduced by half. It's a measure of how long the drug stays active in the body before it is eliminated. For understanding the half-life, let's look at an example. Let's say you take a 200 milligrams dose of ibuprofen for a headache. After taking the pill starts being absorbed and blood concentration levels rise for the first hour. This is absorption phase. About 1 to 2 hours after taking it, ibuprofen reaches its peak level, providing maximum pain relief. This is peak concentration Cmax. During distribution and elimination phase, the ibuprofen starts to spread through your body, reducing inflammation. Meanwhile, your liver and kidneys begin breaking it down and removing it from the body, so the concentration gradually drops. By using this formula, we can calculate half-life. Let's say we got half-life of ibuprofen is 2 hours. That means every 2 hours, the concentration reduces by half, and after about 6 hours, the level is low enough that you might need another dose if pain continues. In summary, you have taken ibuprofen 200 milligrams. We got half-life of ibuprofen, that is 2 hours. So, you took the drug after 2 hours. The doctors took the blood sample and measured the drug concentration. They get 100 milligrams, the concentration of drug reduced to half. Later, after 2 hours, they took the sample and measured the drug concentration in blood. They get 50 milligrams again if reduced to half. They repeated the same after 2 hours. They get 25 milligrams, same, it reduced to half. If you observe this pattern, for every 2 hours, the concentration reduced to half. So, the half-life is 2 hours. Let's see the definition. The half-life, T1/2, is the time it takes for the concentration of a drug in the body to be reduced by half. After 6 hours, the level is low enough that you might need another dose if pain continues. Because 25 milligrams of ibuprofen is not enough to produce therapeutic effect. Peak plasma concentration, Cmax. Peak plasma concentration, Cmax, is the highest level a drug reaches in your bloodstream after you take it. This is the point where the drug's effect is often the strongest because there's the most drug in your blood at that moment. The highlighted part in the graph is the peak concentration of drug in blood. So, this peak point is nothing but Cmax. Time of peak concentration, Tmax, is the time it takes for a drug to reach its highest level or peak concentration, Cmax, in your bloodstream after you take it. When you take a pill, it's absorbed into your bloodstream over time. The concentration of the drug in the blood gradually increases until it hits its peak, Cmax. The time it takes to reach this peak is the Tmax. Simply look at the x-axis at how much time peak happened. That is simply Tmax. After Tmax, the concentration starts to fall as the body metabolizes and eliminates the drug. What more can we learn from the plasma drug concentration versus time profile? Well, let me introduce another term, area under the curve, AUC. The area under the curve, AUC, is a measure of the total exposure your body has to a drug over time after you take it. Imagine plotting a graph of drug concentration in your bloodstream over time, where the concentration starts low, rises to a peak, and then falls as the drug is broken down and leaves your body. The area under this curve represents the entire amount of drug your body has been exposed to during that time. The area under the curve, AUC, is simply the area beneath the curve on this graph. It is nothing but the total exposure your body has to the drug over the period of time. Exposure means how much of the drug is in the system and for how long. A larger AUC means you have been exposed to more of the drug over the time. A smaller AUC means less exposure. Here in this graph, the highlighted area is nothing but AUC. Let's look at another graph. This whole hexagonal-shaped area is nothing but AUC, which tell us about overall drug exposure. Let's look at the uses of AUC. Why do doctors and scientists use AUC? AUC helps them compare drug effects. AUC allows doctors to see how different doses or forms of the same drug affect total exposure. For instance, comparing AUC for a pill versus a liquid form of a drug can show which one provides more sustained exposure. Adjust doses. If a patient's AUC is too low, it may mean they need a higher dose for the drug to work. If it's too high, they might need a lower dose to avoid side effects. Personalized treatment. AUC can vary based on factors like age, weight, kidney, or liver health, so doctors can adjust the dose based on individual needs. Various pharmacodynamic parameters we can get from graph. We can get minimum effective concentration, MEC. MEC is the lowest concentration of a drug needed to produce a therapeutic effect. We can get maximum safe concentration, MSE, or minimum toxic concentration, MTC, is the lowest concentration that starts to produce toxic effects. We can get onset of action. The onset of action is the time it takes for a drug to begin to have its intended effect after administration. Example, after taking ibuprofen for a headache, it might take about 15 to 30 minutes for you to start feeling pain relief. This period is the onset of action. We can get onset time. Onset time is the amount of time it takes for a drug to start working after it is administered. In simple terms, it's the time between when you take the drug, like a pill, injection, or inhalation, and when you first start feeling its effects. We can get duration of action. This is the length of time a drug's effects last in the body after a single dose. Example, if you take a sleeping pill that helps you sleep for 8 hours, the duration of action for that dose is 8 hours. We can get therapeutic range. The therapeutic range is a range of drug concentration in the bloodstream where the drug is effective without being toxic. In other words, it's the sweet spot where the drug does its job safely. Let's breaking it down in simple terms. Below the therapeutic range is a drug concentration is too low to be effective, so the drug may not work as intended. Within the therapeutic range is the concentration is just right for the drug to be effective and safe. Above the therapeutic range is the concentration is too high, which could lead to toxic side effects. Example, for an antibiotic, the therapeutic range might be 10 to 20 milligrams per liter. If the drug concentration is kept in this range, it can fight the infection effectively. If the level falls below 10 milligrams per liter, the infection may not be treated properly. If it rises above 20 milligrams per liter, it could cause harmful side effects. Now, let's focus on an important topic. What is rate of reaction? Rate of a reaction is nothing but speed of a reaction. It describes how quickly a chemical reaction happens. For example, if you dissolve an antacid tablet in water, it starts fizzing. The rate of reaction would tell us how fast the tablet dissolves and releases gas. That's it. It's that simple. It's the speed at which reactants, that means starting substances, turn into products, which are new substances. Some reactions happen very fast, like an explosion, while others are slow, like rust forming on iron. There are many types of rate of reaction. Zero-order reaction and first-order reaction is the common ones. Let's look an example. Magnesium react with oxygen to form magnesium oxide. Here, magnesium and oxygen are reactants. Magnesium oxide is final product. If you increase the concentration of reactants, but the speed at which the final product formed is not changed, then we can say it follows zero-order reaction. But if the concentration of reactants increases and then the speed of reaction increases, we can say it follows first-order reaction. In summary, zero-order means rate is constant, independent of concentration. First order means rate is proportional to the concentration of the reactant. Now we will discuss another important topic called compartment models. Before going into compartment models, let me give you some backstory. Like, what are these models? Why are we studying about them? As I said earlier, at the Introduction to Clinical Pharmacokinetics, we get the data from pharmacokinetic studies, and doctors use that data to help patients. Right. Now, there's a problem here. Let's look at this example. The patient was given a drug, tablet, or injection. The drugs gets absorbed, distributed, metabolized, and excreted. Now, we want to know how much it's absorbed, distributed, metabolized, and excreted. For absorption, we can draw blood samples periodically and measure the drug concentration in blood. Even though drawing the blood sample periodically, like say every hour, is difficult and uncomfortable to patient, let's say, we can do that. But after absorption, the drug enters distribution phase and gets distributed to different parts of the body, like organs like heart, lungs, etc., and tissues like adipose tissues. The problem here is, how can we measure them? If the drug gets distributed to heart and we want to know the drug distribution, we cannot take a sample from heart or any other's organs, but we need to get data. How we can get that data? We have only a limited amount of data. Here we obtain the remaining data with the use of mathematical models by using the available limited data. What are these mathematical models? Well, these are called pharmacokinetic models. Out of 4 mathematical models, compartment model is one of them. Now, let's look at the compartment models. Here, a person was given an 4 injection of a drug. The drug first enters the bloodstream. Later, it gets distributed throughout the body. Now, let's focus on this distribution pattern. First, the drug enters the bloodstream. Later, in distribution phase, the drug generally enters the vital organs like heart, liver, kidney, lungs, etc. These organs are in close contact with blood. That is, they are highly perfused with blood continuously. After these organs, The drugs enter the remaining parts of the body like tissues, muscles, skin, etc. That is distribution phase. From there, the drugs will return from the tissues, vital organs to liver. Why? Because after distribution, metabolism occurs. And metabolism occurs in liver. From there, drug reach to kidney for excretion phase and gets eliminated from the body. This is the route map of the drug. Now in compartment models, the whole body is divided into compartments. Like they name these organs as central compartment and the remaining tissues, muscles, etc. as peripheral compartments. Now let's look at some real-life examples. Here, for a drug like paracetamol, which mainly stays in the bloodstream and is quickly eliminated, the entire body acts as a single space or compartment. We don't need to think about separate compartments because the drug doesn't significantly move into deeper tissues. The drug spreads evenly and then leaves the body through the bloodstream. Now let's look at another example. For a drug like diazepam, which moves into the bloodstream first but then spreads into fat tissue, a two-compartment model is useful. The bloodstream acts as the central compartment, and fat or muscle tissue acts as the peripheral compartment. Diazepam first concentrates in the bloodstream, then gradually moves into tissues where it stays longer. Eventually, it returns to the bloodstream for elimination, but this process takes more time because of its distribution in multiple compartments. Now in compartment models, based on the number of compartments involved, they are classified into the following types. One-compartment model. Here, the entire body is a single space where the drug is evenly distributed and eliminated. Two-compartment model. This model divides into a central compartment, bloodstream, and one peripheral compartment, other tissues, for back and forth distribution. Multi-compartment model. This model contains one central compartment and multiple peripheral compartments, useful for drugs with complex distribution patterns. This classification is based on how many compartments are used to represent the body in the model. Again, compartment models are classified based on structure into two types: mammillary model and catenary model. Don't get confused. The previous classification of compartment model is based on how many compartments, like number of compartments used. This classification of compartment model is based on structure, like how they are connected. Now let's look at mammillary model. In the mammillary model, the drug first enters the bloodstream, the central hub. From there, it spreads out to different organs or tissues, the spokes, but always comes back to the bloodstream. Each body part acts like a compartment connected directly to the bloodstream. Example: consider a drug like morphine. When taken, it quickly enters the bloodstream, the hub, then travels to various parts like the brain, kidneys, and liver, the spokes. These organs don't hold on to the drug permanently. It returns to the bloodstream for further distribution or elimination. Let's look at this example. Here the drug first enters the central compartment V1 and later enters to peripheral compartments like V2 and V3. Notice that the blood from peripheral compartments return to central compartment. From there it goes to liver for metabolism and kidneys for excretion. This kind of explanation is mammillary model. Let's look at another type, catenary model. Another type of compartment model called catenary model consists of compartments joined to one another in a row or series like the compartments of a train. In contrast, the mammillary model consists of one or more compartments around a central compartment like satellites. Since most of the functional organs of the body are directly connected to the plasma, catenary model is not used as often used as the mammillary model. Let's look at the example. You can look, all the compartments are connected in a series like a chain. Now let's see the practical application of pharmacokinetics using a one-compartment open model, which simplifies the body into a single compartment. This approach assumes that after the drug is absorbed, it evenly distributes throughout the body as if it were in one large compartment. Some key metrics, that is pharmacokinetic parameters, are used to understand and predict drug behavior in this single compartment system. Those key metrics are elimination rate constant, volume of distribution, half-life, clearance. Let's look at them one by one. First, elimination rate constant. This parameter, the elimination rate constant, tells us how fast a drug is eliminated from the body. It is a constant that represents the fraction of the drug that is removed from the body per unit of time. It is expressed in units like per hour or per minute, meaning how much of the drug is removed from the body each hour or minute. Let's simplify this. If a drug has a high elimination rate constant, it means the body is getting rid of the drug quickly. A low elimination rate constant means the drug stays in the body longer and is cleared slowly. Example: imagine you have a drug in the bloodstream that gets eliminated by 10% each hour. This would be reflected in the elimination rate constant. If the elimination rate constant is 0.1 per hour, it means 10% of the drug is removed from the body every hour. Second parameter is volume of distribution. In simple terms, the volume of distribution is the theoretical volume that would be needed to hold the total amount of drug in the body at the same concentration as it is in the blood. It's not an actual physical space, but a concept that gives us an idea of how widely a drug disperses. High volume of distribution means the drug spreads widely into tissues outside the blood. The drug doesn't stay in the bloodstream very long because it's moving into organs, muscles, or fat. Low volume of distribution means the drug mostly stays in the blood, so less of it is reaching other tissue. In this example, let's say, if this drug has lower volume of distribution, we can conclude that it majorly stays in the blood, less of it reaches deeper tissues. If this drug has high volume of distribution, we can conclude that it can widely spread into the blood and deeper tissues. For example, a drug like warfarin, a blood thinner, has a low volume of distribution because it mostly stays in the blood to work on preventing blood clots. On the other hand, a drug like digoxin, used for heart conditions, has a high volume of distribution because it moves into and acts within muscle tissues, including the heart muscle. So in summary, volume of distribution is a way to understand where a drug goes in the body. A low volume means the drug stays mainly in the blood, while a high volume means the drug spreads into other tissues. This concept helps doctors determine dosing to ensure the drug reaches the intended tissues effectively. So, the formula to calculate this volume of distribution is this. The third parameter is half-life. We already explained this, but let me give you a quick overview. The half-life is the time it takes for the concentration of a drug in the body to be reduced by half. It's a measure of how long the drug stays active in the body before it is eliminated. This is the formula used to calculate a half-life. And the last parameter is clearance. Clearance is a measure of the body's ability to remove the drug. It tells us how much volume of plasma is cleared of the drug per unit of time, usually in liters per hour. Clearance is a combination of both metabolism, how the liver processes the drug, and excretion, how the kidneys remove the drug. Let us simplify that. High clearance means the body is very efficient at removing the drug. Low clearance means the drug stays in the body for longer periods. This is a formula that is used to calculate clearance. Let me explain the things in the formula. Total clearance. This is the total volume of plasma from which the drug is cleared per unit of time, considering all elimination pathways. Renal clearance. This represents the volume of plasma cleared of the drug through the kidneys. This is the amount of drug removed from the bloodstream through urine. Non-renal clearance. This refers to the clearance of the drug through other routes like the liver, metabolism, lungs, or bile. These are processes where the drug is broken down, metabolized, or excreted other than through the kidneys. I hope you understand this topic introduction to clinical pharmacokinetics. The notes for this topic is available in our website. Do check out. This is our website. Thanks for watching.